My dear students, welcome to the second module of video radiographs. In previous video, you were able to enumerate the types of shadows in radiograph. Now you are aware of positions of source, subject and film in radiographic procedure, that is X-rays. You are also aware of exposure time and intensity of X-rays and how it affects the quality of film. Now you have been enabled to explain what is view in radiographs. You are also able now to differentiate between plane X-rays and contrast X-rays. In this module, we are discussing some simple radiographs of limbs. Before we proceed to look at the protocol on which we should read radiograph of limbs, I have a question to you. This is a plain radiograph of hand. Can you tell me which side does it belong to? I know some of you are decided with right side and some of you are decided with left side. Now I flip the X-ray on the board. Can you decide the side now? It is not possible to say the side of the limb only by looking at X-ray unless a technician mentions the side on the film. It is always mandatory to mention the side of the limb while taking X-rays. This is how the technician has mentioned. It is belonging to right hand. It is not photograph. It is like a negative of a photograph which can be seen from either sides, but side has to be determined by lead letter which is kept by the side of the limb on the film before taking X-ray. Now let us look at the points to be covered while reading any radiographs of limb. First of all, you should mention whether it is plain X-ray or contrast X-ray. Yes, contrast radiographs are also possible in limbs when we inject some radio opaque substances in arteries or vessels. Most of the time, the limb radiographs are plain variety. Second point you should mention for limb especially is side, which side it is belonging to. You can comment it very strongly and confidently by looking at the lead letter R or L, which is mentioned by the side of. Third point, what you should mention is about the region or area of interest, what is actually focused. You should not forget to mention about the view, whether it is AP view, lateral view, oblique view. Finally, you should conclude by saying what it is showing, what bones are shown, which joints are exposed in the field, and you should not forget to mention about soft tissues around as well. So these are some of the protocols which have to be covered while reading radiographs of limbs. Let us look at the first. So how to read this radiograph? This is plain radiograph of right hand AP weave showing lower part of radius, ulna, carpal bones, metacarpal bones, and phalanges with soft tissue around. This completes the reading. I repeat, this is plain radiograph of right hand AP weave showing lower part of radius, ulna, carpal bones, metacarpal bones, and phalanges with soft tissue around. You need not diagnose any defects. Just read and identify normal anatomy. When we look at bones, this is radius, this is styloid process of radius, this is styloid process of ulna. These are next questions which you might have to answer, which examiners picks for you. He may ask you for identification of carpal bones. This is radial side first row, scaphoid, lunate, triquetral and pisiform. Triquetral and pisiform are overlapping here. You can see this P-shaped round dense shadow, that is because of overlapping of pisiform and on triquetral. This is trapezium, trapezoid, capitate, this is head of the capitate, and this is hamate, this is hook of the hamate. And all these are metacarpal bones. First metacarpal, fifth metacarpal. Here bases of fourth and fifth metacarpal are overlapping, that's why there is a dense shadow. At the head of first metacarpal bone, there is a sesamoid bone, which might be seen in tendon of flexor pollicis longus and phalanges. When we look at next radiograph, you try your own to read it. Plain radiograph of left wrist joint AP view showing lower part of radius, ulna, carpal bones, metacarpal bones, and proximal phalanges. Here, or both phalanges. So why I said area of interest or region wrist joint? Because here the centrally focused area is wrist. This is the area of interest. You can see here styloid process of ulna. This is scaphoid, lunate, triquetral, pisiform, trapezium, trapezoid, capitate, and hamate. This is hook of the hamate. This is of left side. Let us look at the next one. Plain radiograph of right forearm AP weave showing lower part of humerus, both radius and ulna, carpal bones with soft tissue around. Here you can identify radial tuberosity, head of the radius, the lower broad end of the radius, the lower narrow end of the ulna. One more thing you can easily identify here is the medullary cavity. You can see medullary cavity is, compared to whole bone, it is little radiolucent, but the borders of long bones are denser because these are cortical bones, compact bone. Here, because of medullary cavity, it shows some lucency, radiolucency. To read this radiograph on your own. This is plain radiograph of elbow. Yes, definitely, we are not able to say which side this belongs to because there is no marked letter here, whether it is R, right or left. Area of interest is elbow joint, showing lower part of the humerus, upper part of radius and ulna. Both AP weave and this is lateral weave. Here we can see head of the radius, radial tuberosity, coronoid process, olecranon process, which is fitting in olecranon fossa of humerus, lateral and medial epicondyles of humerus. This dark shadow is because of overlapping of ulna, coronoid process on part of the head of the radius and neck of the radius. So this is because of overlapping we are seeing dense shadow. You can again make out medullary cavity and cortical bone. This is plain radiograph of right shoulder joint showing upper part of the humerus, scapula, clavicle and ribs of the left side, right side and partly the vertebrae, thoracic and cervical with soft tissue around. It is also showing right lung field which is radiolucent. But area of interest is shoulder joint. If it is chest X-ray, usually it is taken for both lungs and cardiac area as well. You can see here medullary cavity of humerus. In exams, you might have to identify the different parts of scapula. Can you make out the borders of scapula? This is glenoid cavity. This is lateral border of scapula. This is inferior angle of scapula. You can see this shadow here, the line. This is medial border of scapula. This becomes upper angle of scapula, and this is coracoid process of scapula, and this is spine and acromion process of scapula. And this is lateral end of clavicle. This is medial end of clavicle. Examiner can also ask you about the ribs. Can you show the first rib? Outline of the first rib can be made out here. So this is the shadow of first rib. This is the outer border of first rib, and this is inner border of the first rib. And this is second rib. This is third rib. and this is fourth rib. These are the spines of. We'll cover these things little later when uh, we look at the spine and thoracic region separately. This is plain radiograph of right foot AP view and lateral view showing lower ends of tibia, fibula, tarsal bones, metatarsal bones and phalanges with soft tissues around. Once you read this, you might have to identify different tarsal bones. This is calcaneum. Because of the overlapping, the shadow is more dense here. We can say it is underexposed for this area. And you can identify a few sesamoid bones here at the head of first metatarsal bone for flexor hallucis longus. And you need not identify the defects, but here there is a defect. Here you can see there is a fracture here at the fifth metatarsal head. This is the line of fracture. Even if you don't identify the defects, it is okay. You should be able to identify the normal anatomy. So this is plain radiograph of both right and left ankle joints. Oblique views. Both are oblique views, showing lower part of the tibia and fibula, which are overlapped here, showing dense shadow. Calcaneum, thallus, navicular bone and cuboidal bones are overlapping, and you're also observing metatarsal bones with soft tissues around. Again, this is plain radiograph of left foot. This is AP view, this is oblique view, this is lateral view, this is again AP view, showing bones of lower and lower leg, metatarsals and metatarsals and tarsals with phalanges. Come to this radiograph. This is plain radiograph in the upper part. I'm speaking now here. Plain radiograph of right and left knee joint, showing lower part of the femur, upper part of tibia and fibula, knee joint, as well as this is the shadow. Can you make out? This is the shadow of patella, making dense shadow. Here this is left patella. Both right and left knee joints are exposed. AP view, in AP view. And in the lower part it is plain X-ray or plain radiograph of both right and left knee joints, lateral views showing lower ends of femur, patella, upper ends of tibia and fibula, with soft tissues around. You can see here the joint space of knee. Let us look at this radiograph. This is the joint space of knee. This is again plain radiograph of left knee AP view showing lower end of femur and upper end of tibia and fibula with soft tissues around. This is the patellar shadow and you can see joint space. These articular surfaces are covered by cartilage, hyaline cartilage, which are radiolucent. Even though cartilages are in contact in standing position, they are not picked up by radiographs. They are allowing the rays to pass through, they become radiolucent, and we see the joint space. If cartilages are worn out, or if they are uh, there is erosion of the cartilages, the joint space becomes lesser and lesser. The bony uh, ends come together because there is lesser cartilage. And this is the lateral view. I cannot determine the side here because it is separate X-ray. This is lower end of femur, this is patella, tibia and fibula. This is in flex position. This is lateral view. This is radiograph of pelvis. How to read this radiograph? This is plain radiograph of pelvis, AP view. You need not mention the side here because one mistake in this radiograph is they have to mention the side, whether this is right or this is right or which is left. Only one side they have to mention for clinical application of this investigation. So maybe I have cropped it. So this is plain radiograph of pelvis AP view showing hip bone, upper ends of femur, hip joints both, pubic symphysis and sacrum and lower lumbar vertebrae. You can see this is coccyx, this is sacrum. Sacroiliac joints are seen and with soft tissue shadows around. So you might have to identify the parts of hip bone. This is ilium, this is acetabular fossa, and this is pubic symphysis, which are coming together, pubic bones, and this is ischium. Ischium. I cannot say which is right and left because there is no mark here. And this is lesser trochanter, greater trochanter, neck of the femur and head of the femur. And you can see medullary cavity and the cortical dense bone. So these are the few points you might have to pick up. And if you answer everything, there are certain other things to be answered by your exam for your examiner. These shadows, these are black shadows of gas in bolus intestine. So to summarize, now you are enabled to read plain x-rays of limb. So some points to be covered while reading plain x-rays are whether they're plain or contrast, side of the limb if it is limb particular, region or area of interest, view whether it is AP view or lateral view, and what it shows, bones, joints and soft tissues around. Thank you.